Never think hard about the past. It brings tears in your eyes. Don't think more about the future. It brings fears of future. Live this moment with smile. It brings cheers. Whatever you have, enjoy it. Otherwise, you will not be able to have this time again. So enjoy this moment. Now, the diagnosis of the gout, history and the physical examination, synovial fluid examination for MSU crystal, which are characteristic of this gout, blood test, uric acid level, RA factor, anti-CCP level, renal function test, urine examination, urinary uric acid level, if that is less than 800 milligram under liter per deciliter in 24 hours. Imaging X-ray to show calcium or uric acid deposit, tophi or the bone erosion, martel signs, sclerosis and joint space narrowing, CT scan, MRI, ultrasound, bone scan. These have got no value in diagnosis of the gout. So here one can see uric acid crystal on arthrocentesis. The joint fluid is taken out, and that is the axis of the crystal is very important. So you have to see the axis of the crystal. These are just as one can see in this slide. These just keep their position according to the axis. Then one can see the X-ray, the bone which have been eaten up, then the tophi in the bone that can be also seen on X-ray. Now, the differential diagnosis of the gout is pseudo-gout, infected joint, septic arthritis, bacterial skin infection, cellulitis, stress fracture, rheumatoid arthritis, psoriatic arthritis. All these diseases have their classical picture, and these cannot be these cannot mimic with the true gout, so one can differentiate by their special specific feature which each of this disease do have. Now, coming to the treatment, in old times, lithium salt were used. Today, there are three goals of the management. Number one, to terminate and to treat acute painful attack. And number two, prevent the recurrences. And number three, to reverse complications in the joints, kidneys, or the other organs which are involved and the other sites which are involved. Treatment, it is of two main types. One is non-pharmacological and the other is pharmacological. So the first non-pharmacological treatment decrease the amount of the alcohol intake and the meat which are responsible for increasing the urate production. Dietary restriction not help much, but avoid foods that trigger gout attacks. No association with the total protein or the purine rich vegetables. Low fat dairy products may be protective in nature. Vitamin C is said to be uricosuric. Patient education for the weight loss is also important. Now, coming to the main pharmacological treatment, medication used to treat and prevent attack. There are two main groups of the medicine. One is for the acute gout treatment and other is for the chronic gout treatment. So the first we are going to the acute gout treatment. Aim and the goal is to decrease severe pain and the inflammation of the joints. These are number one, non-steroidal anti-inflammatory drugs, COX-1 and COX-2 for those who are unable to tolerate non-steroidal anti-inflammatory drugs which cause the gut irritation, gastritis and gastric ulcer. So one can opt for the COX-1 and COX-2. Number 2 is the colchicine. Number 3, corticosteroid. Number 4, analgesic. And number 5, other drugs which can be used. First, non-steroidal anti-inflammatory drugs are COX-1 and COX-2, indomethacin, diclofenac, naproxen, ibuprofen, ketoprofen, oxaprofen, etodolac, and solindac. In gut problem, use stomach-friendly COX-1 and COX-2 inhibitors or the proton pump inhibitors in with these indomethacin and diclofenac so that to combat that gastric irritation problem and take all symptom till symptom relief, and these medicine according to your stomach condition you can have these. Number 2 medicine is colchicine. It is an antimitotic drug from roots of the herb colchicum thumbnail. Oldest treatment for the gout, affects neutrophil migration into the joints and relieve the pain. 2 tablets stand, then one every 2 hours till the pain subside is ideal treatment for the acute attack or when the side effect of the colchicine occurs. These are nausea, vomiting, diarrhea, and abdominal cramps, which a patient cannot tolerate. So stop these drugs, the colchicine. So here one can see the colchicine tablet 0.5 milligram, and this is anakinra, that is IL-2 inhibitor. Next slide you will be able to see that how it do have its effect. It is also available in injectable form to just combat that IL-1 receptor and to give the relief. Number 3, the corticosteroid used orally, intramuscularly, intravenously, or intraarticularly into the joint. Prednisone, prednisolone, and triamcinolone are the drugs which are used, or one can use injection of the adrenocorticotropic hormone ACTH. It just directs adrenal gland to make more cortisone. And number 4 are the analgesic. Different kinds of the analgesic from mild, moderate, and even narcotic analgesic can be used to give relief to the pain. These are morphine, pentazocine, nalbuphine, etc. can be used for the immediate pain relief. Now the other group, that is anti-IL-1 drug, anakinra, subcutaneous injections 100 milligram daily for 3 days for the pain relief, well tolerated and efficacious in flares, but it is expensive, not within the reach of every person. Used when gout is refractory to the non-steroidal anti-inflammatory drugs, colchicine or the steroid cannot be used, so one can go for this anti-IL-1 antagonist. Classical picture, and just see the kid is just taking milk directly from the cow, and cow is just not having any kind of reaction to allow the kid to have the milk for the really marvelous picture and impressive picture for the animals who are just giving benefit to the human being. Now coming to the chronic gout treatment, goal of the therapy is to prevent an acute attack by decreasing uric acid level. There are 3 groups which are being used for this treatment. Number 1, uricostatics, xanthine oxidase inhibitor. I have already told you the enzyme responsible for making the uric acid. Then uricosurics, which excrete the excess uric acid. Then uricolytics, the uricase enzyme, which just causes the lysis of the uric acid by the enzyme uricase. Now treatment, chronic gout, uricostatic, uricosuric, and uricolytic. So first, uricostatic. These are xanthine oxidase inhibitor. These are purine analog structural isomer of the hypoxanthine and the potent inhibitor of the enzyme xanthine oxidase dehydrogenase responsible for production of the uric acid. These include allopurinol, fuboxetat, oxypurinol, and others like tisopurine, inositols, phytic acid, myoinositol, and topiroxostat. So the first, the allopurinol and febuxostat, these are xanthine oxidase inhibitor. As we know, the purine nucleotide and purine nucleotide are going to make the hypoxanthine, and this hypoxanthine is going to make xanthine, and this xanthine is going to change into the uric acid. So these medicine, xanthine oxidase emitter, these are allopurinol or febuxostat. These, just as one can see, these block this xanthine oxidase inhibitor, so hypoxanthine cannot change to the xanthine. And here they again block the xanthine converting to the uric acid, and that is just going to change to the allantoin by the action of the uricase, and the uric acid production is lessened. Now, xanthine oxidase emitter, these are called uricostatic. These just does not allow the increased level of the uric acid by just inhibiting the production of the uric acid. For that reason, these are called uricostatic, but they are not capable of decreasing the uric acid, which is already in the body, that is by the uricosuric drugs or by the uricolytic drugs. So xanthine oxidase inhibitor, these act by decreasing amount of the uric acid production by the body, useful for the patients who produce excessive amount of the uric acid in their body. These are called overproducers. Those who excrete more than 800 milligrams of urate in 24 hours in the urine. The drug is taken by mouth or injected into the vein. Not recommended during gout attack, patient with renal failure, that is the contraindication. It has got many drug interaction and many side effects. Here one can see the xanthine oxidase inhibitor, allopurinol 100 milligram, 300 milligram, and oxypurinol, that is 100 milligram, that is also being used as xanthine oxidase inhibitor. So, continuing the uricosuric agents, the second group, these block function of the protein urate transport 1 or urate 1, which is responsible for transport of uric acid back or reabsorption of the uric acid from the kidney into the blood and causing hyperuricemia. These drugs help kidney get rid of the excess uric acid produced in the body for the patient which are under excretors of the uric acid, not the overproducer. Patients on the uricosuric agents are at high risk for the urolithiasis, and this can be decreased by adding sodium bicarbonate 1 gram 3 times a day and hydration, that will just prevent the urolithiasis in the kidney, because as the uric acid is being excreted more from the kidney towards the urine. Here, try to understand, that is the racinoid mechanism of action, which is urate 1 inhibitor. So here one can see the uric acid that is coming to the glomerulus, and one can see the size of the arrow. The filtration is more. So here these medicine are going to block LRT URAT, which is responsible for reabsorption of the uric acid about 90% back into the blood. So, if these drugs are just going to block the reabsorption, so there will be decreased reabsorption, and you can see the size of the arrow that indicates the uric acid load. So the less uric acid will be going into the blood, and the more is going and coming to the tubules, and ultimately that is going to cause the increased excretion. So here is the lesinurad, the green color, which are going to block here the urate 1, and these are not capable of reabsorbing the uric acid back into the blood. So here one can see the urate, and that is being blocked by these urate 1 blockers. These are the lesinurad, the green color, and they are just blocking the absorption of the uric acid back into the blood and helping to excrete as the size is indicating. The more excretion is there and the less is reabsorption. Now, uricosuric agents, these are of two types, primary uricosuric and secondary uricosuric. Primary uricosurics excrete uric acid from the kidney via the known mechanism. They include, just to remember, SIP-PIR, probenecid, sulfenpyrazole, benzbromarone, and isobromidone. SIP-PIR, that is SIP, and benzobromarone for beer. So here one can see the uricosuric agents. These are the probenecid, sulfenpyrazole, isobromidone, and benzbromarone, which are responsible for causing uricosuric effect. Now, the secondary uricosuric, these are drugs for some other primary use, but with the known uricosuric properties, they excrete uric acid from the kidney via unknown mechanism, and they include amlodipine, losartan, antihypertensive drugs, atorvastatin, lipid-lowering drug, cholesterol-lowering drug, fenofibrate, low triglyceride, raises HDL, guanfacine is expectorant, lesinurad, already I have told you, adrenocorticotropic hormone, cortisone, and abdominal surgery also has a uricosuric effect. So here one can see amlodipine, losartan, atorvastatin, fenofibrate, guanfacine, and lesinurad. Now, the third group is uricolytics. These are uricase enzyme responsible for causing the lysis of the uric acid. Enzyme uricase or urate oxidase, absent in the humans but present in the carnivores. These catalyzes oxidation of the uric acid to 5-hydroxy isourate, which ultimately converts to the allantoin. Allantoin is highly soluble in plasma and easily excreted through kidney, as it is in case of the animals carnivore. So here one can see uric acid changes to the 5-hydroxy isourate, and ultimately by the effect of the uricase enzyme, it is going to change to the allantoin, which is recycled and used in the body. So here one can understand the action of the uricase enzyme. Purine catabolism lead to the xanthine, hypoxanthine, and here xanthine oxidase inhibitor is capable of stopping the production of the uric acid, and there is low urinary excretion. And here, if still that xanthine oxidase inhibitor and the uricosuric drugs are not affecting, so here one can use the urate oxidase that is capable of just catalyzing the uric acid to the allantoin, and there is high urinary excretion. Similarly, as one can see, as the uric acid has low solubility, uricase enzyme changes it to the allantoin, which have high solubility, and it is excreted through the kidney very amicably. Now, uricase enzyme is effective in diverse forms of the hyperuricemia like refractory gout, not responding to the other treatment, removing the pre-existing urate crystal in the joints. These enzymes include pegloticase, available by the name of Cristaxa, a recombinant mammalian uricase with MPEG for long action. The other enzyme is rasburicase, that is available by the name of Alitec, a recombinant fungal uricase without structural modification as it is being used. So here one can see Cristaxa, pegloticase, and Alitec, that is rasburicase, IV infusion taken from the fungus. So now this is the summary of the gout and the uric acid metabolism. Nucleic acid in the body cells, these just when break down to the purines, purines ultimately change to the hypoxanthine, and hypoxanthine under the influence of the enzyme xanthine oxidase changes to the xanthine, and here the effect of the allopurinol or febuxostat, which is xanthine oxidase inhibitor, as one can see the negative signs, they can stop the production of hypoxanthine to the xanthine, and similarly the xanthine that changes to the uric acid, here again the xanthine oxidase inhibitor can act and decrease the uric acid production. And if these are not working, uric acid produced and the urate oxidase, the enzyme rasburicase, and the other drugs which are uricosuric drug like sulfenpyrazone or probenecid, they are able to excrete the uric acid by the renal excretion, and that is just going to change the uric acid into the allantoin, which is water soluble metabolite, and it is easily excreted by the kidney. So that is the summary of the uric acid and the gout. Now, some interesting facts about the uric acid. Why gout first occur in the foot? Why? Because this area is slightly colder than central part of the body. This disturbs solubility of the uric acid in the blood, so it get deposit here. Another colder area is rim of the ear, and these are furthermost part of the body with least circulation, so that is also one of the reason. Uric acid crystals causing pain and inflammation due to the rush of the white blood cells that arrive at the pain point detecting a virus or the bacteria. So inflammation, chemotaxis that attract the WBCs, and these are responsible for causing pain. Urates are the potent antioxidant, so increased level of the urates in the humans compared with the lower animals, and it is said that is because of these antioxidant effect of the uric acid that the human beings are having more prolonged life than the animals. So reason of the longer lifespan of the humans, lowering incidence of the human cancer and prolonging the life. Hyperuricemia is linked to aggravate the behavior, and that is aggressive behavior with the patient, those who are having hyperuricemia. So that was all about the gout and uric acid. I have tried to give as good as possible for these two things, uric acid and gout, and hope so you may have liked this lecture. If you do like this lecture, please subscribe this channel and share it with others for information. If you have any question or any query, please contact and no hesitation. And thank you very much